Hey, good morning. Thank you for that wonderful introduction. Hopefully I can live up to it. And yeah, so we're here. In my practice, I've got a patient waiting for us, and we're going to go over, we're going to show how to get these coronary arteries so that you can see how easy it is and how fun it is to do it. All right? I'm ready. All right, so first thing we're going to start with, we're going to get our reference picture. And our reference picture in this instance is looking for our parasternal long axis picture. So as you can see here, we have that. You can adjust your gains, get it to where you would like to have the picture. I think that looks pretty nice. So what we're looking for in here is one that we have a nice LV. It is kind of going upwards just a little bit. We can see the aortic valve really nicely and the mitral valve very nicely. And if you angle just a little bit, you can start seeing this little critter coming up there, and that's going to be your right coronary artery. Right there. And if we do our little sweep and we go inferior, there's this tricuspid valve, and if we start going somewhat superior, then we get to his outflow tract. Make that a little brighter for the camera. And this is a great spot. We can also pick out his left anterior descending is coursing right through here. If we lower the overall 2D gain, you can see that sometimes a little bit better. And then everyone's favorite, we're going to rotate into our parasternal short axis. And this is a good reference view. We want to make sure that we see all three leaflets of his aortic valve. We can already see pieces of his right coronary artery coming in here. So we're going to focus on that one first. And it's strictly out of habit. I always go with the right coronary first. And you just kind of slide your hand around until you think you have a nice picture. And then once you think you do, you can freeze it and kind of come back and forth. And if you feel like you don't have it, then you can go back to live. And there we go. So now we're getting, this is his proximal right coronary artery right in here. You can kind of see it kind of coursing up and taking this course of action right through there. And also while I'm doing this, you can see where my hand position is. So while I'm doing this, I'm also kind of rotating back and forth. I'm sliding left and right. I'm just looking for the best image that I can get. And then I want to see the best image I can get and follow that coronary out as far as what we can. And the reason for that is in pediatrics, we deal a lot with Kawasaki's. So we want to be able to see as far out on this right coronary artery as what we can. So here's his right, and we can see it coursing all the way through here. This little ditzel right there is called his conal artery, first branch off the right. Then you can just adjust the gain, you can adjust your compress, just so that you can try to get as far out in that far field as what you can. See as much of that coronary as you can. And you can see it's a little bit tricky at times, but that's okay. But all it takes is a little patience. So, key things, you can adjust your compress here, you can adjust your overall 2D gain, and that's especially important when you try to put color on in here, because as you have if you have higher gain on here, you start losing your color. So if you take that gain off, you can really start highlighting when you get color into that coronary artery. And getting color in there is very important, because then that lets you know that you're actually within that vessel. So we have some color right in here. You can see color coursing right through there. So we know that we're in that vessel. So then once you've seen that, once you see that it doesn't look like it's dilated or hepatic, and that there is no, that you didn't see any aneurysms, then you can move on. We'll move on to the left here. And the important thing to note with the left is that we want to be able to see this branching pattern. So we're going to end up with his left main, the left anterior descending, and right down in here will be his circumflex. And to get this, I'm going to rotate my dot a little bit clockwise, and that's going to help open up that left anterior descending. So then we can get a nice long course of that coming through here. Right along in here. So you can see a nice long course of his left anterior descending. Start seeing a little bit of more of that circumflex right through here, kind of coursing like so. But you really get a nice long course of that left anterior descending. Once again, we can see this. I've rotated a little bit more. You can see this coursing all the way out through here. And then once again, we'll do the exact same thing with color. Try to get a nice color flow in here. And then you also have to remember physics. So when we're looking at this in 2D, we want to get these, I want the sound beam to be perpendicular to the structure so I can get a nice clear view of it. But when I'm doing color, I have to be a little bit more parallel to that flow. So I may have to move my hand around a little bit to get as parallel to that flow as I can. And sometimes that's a little bit tricky, especially with the left. And showing the color is really important to show that the true origin is there. So once you have a nice picture, then you can try to put the color back on. And once again, there we go. So we get this little jet of color going right in there. This does not have to be crazy. Your gain does not have to be crazy. Remember, these are fed during diastole. So as long as you're, just a tiny bit under that diastolic number, you're going to get color flow. And as long as you maintain that you get ample, that you get as parallel to the flow here is what you can get, you're going to get good color flow as well. Not as good as I would have liked, but I don't want to make Jeff look too bad. So, as you were probably watching before, sometimes you can struggle with these, even if you're good at getting these in. Sometimes with the patient position, as you can see, I've rolled him over just a little bit, and already this right coronary artery comes in a little bit better. So as long as they're old enough and you can have them roll on your side. We can bring it a tad bit higher. How about that? And you can see how that just kind of forces everything into a little bit better view. So now we can follow this out just a little bit further. I can't see the origin right here real well. It's right in here, but we can follow that artery out just a tad bit further. Then adjusting the gain a little bit and kind of rocking back and forth, we can get a little bit more, even a little bit more mid to distal out here, right in there. So we can see just a tad bit further out, which is the name of the game with these. There we go, a bit better. Then we can see a little bit further out on the left. Perfect, okay. So let's look at other views, because heart has multiple views. We take multiple views for a reason. So the next on our list, we'll look right down here on his side at his apicals. So once again, we start with our reference view, looking at his apical four-chamber view. We can see both atrioventricular valves, mitral and tricuspid, atrial and ventricular septum. Here's the left upper vein, right. So as we angle up, now we can see his aortic valve. And if we slide a little bit more cranially, let's see, we'll pause.
Yeah.
All right, so when we're trying to get these, sometimes you'll go a little bit off axis. Normally you want to be way down here and you have like the heart just nice and straight and tall. But for this, we're going to go just a little bit off axis, and we're going to slide up just a little bit more towards his head while angling into that aortic valve. And right here you can see his right coronary artery coming in, and that's it right there. And then once again, you can rotate the transducer left and right. You can angle in, you can angle up a little bit more, you can angle back a little bit more. The whole goal is to get more of this coming in here. So we can see more and more of this coming in. So whenever I'm looking at these coronaries, I really want the internal portion, just like I do here, I want it to be nice and black. And the external portion, like right in here, I want to be nice and white, nice shades of gray through there, because that just accents where that is just a little bit more. So you can see all of that coming in there. Then looking at the left, we're going to kind of do the same thing over here, but we may come back just a little bit more towards the center. All right, so for this young man, we had to kind of go way off axis here. So here's our reference view, here's our four-chamber view. So now we're looking for his left coronary arteries. So we're going to slide way up on him and kind of angle just a little bit higher than I would normally do. But there's his coronary as he breathes back in here. So here's part of his left main coming out. And here's part of his left anterior descending, coming down. And if you're having a hard time seeing it, that's okay. It's tough to see. And sometimes you get these patients that you have to have patience because they're breathing and you can't stop their breathing. So unless they're on a ventilator, then you can do that. But and now as he breathes out and we kind of get our bearings here, we can see this is the left anterior descending, coming, coursing all the way down through here, of course going through the entire front portion of the heart since it is anterior. All right, then we're going to move down to our subcostal images. All right, so you can lie on your back. There we go. Once again, we're going to get our reference view down here. And bear with me, all you adult folks, because we are going to turn this over. Sorry, very much a habit. So I like to start here. We elongate. We look at his IVC. Here's his, a, 'Abdominal aorta, and then we're going to upside down here. So for here, I'm going to angle up until we get into the aorta, which is right in here. May not point at there's his aorta. And we're going to just rotate a little bit down. And there's part of his left main. Okay, so once we have this view, so we're subcostally, I've rotated just enough here and angled up until we're into the aorta. And then I'm gonna have you take a big breath in and hold it for me.
Okay.
And then we can see his left coronary artery coming up here. And then we also see part of his right coronary artery right in here. And breathe and relax. So we get his right coming in right through here. And the nice thing with this is it's sometimes hard to get while they're normal sized, but if they are dilated or if there are aneurysms in here, they do become much simpler to see. Once again, there's his left main. And the right coronary artery right in there. And sometimes these are tough to see. So that's really about it as far as coronaries. Those are the views that you can see it. You can go high into the suprasternal region and kind of come back down into a high parasternal short axis view. Sometimes that'll bring in the coronaries a little bit better. We were kind of doing that when we were down there. We were sliding up instead of sliding down. It's all personal preference. Practice subcostals. Those can be a little bit challenging, especially with bigger kids. And always practice in the apicals. It works great, especially in a lot of the adult patients, if you can get in there. So don't think that you're limited to just the parasternal short axis. As we saw, we can see them parasternal long, parasternal short, apicals, and subcostals. So every view that you get, you can try to track down some coronaries. And it can be very important when you're looking at the proximal portion for like this large cell stuff, and you might end up with like all this kind of granulomous, nasty looking stuff. Or whether you're looking for Kawasaki disease, or God forbid, I hate to even bring it up, but MISC, since I also had coronary involvement. But all this stuff is very important. I hope you were able to see it. I hope you understood it, hope you liked it, and thank you for inviting me.